Thank you, everybody. Good morning. It's my distinct honor and privilege to introduce Dr. Hannah Wunsch to deliver the next lecture, which I look forward to greatly. Dr. Wunsch is an intensive care physician in the Department of Critical Care Medicine at Sunnybrook Hospital and professor in the Department of Anesthesiology and Pain Medicine, as well as Critical Care at the University of Toronto. She's the Associate Director of Critical Care Research there and holds a Canada Research Chair in Critical Care Organization and Outcomes. She's the author of the book, The Autumn Ghost, How the Battle Against a Polio Epidemic Revolutionized Modern Medical Care, which is available on Amazon. Please join me in welcoming Dr. Wunsch.
Thank you very much. Really an honor to be here. Thank you. This place is spectacular, and it's a real pleasure to get to share with you a little bit of history, but also I hope you will take away from it some points that are certainly relevant to the care that you provide now and will be providing in the future. I have, as actually of 3 weeks ago, I've actually moved to New York City, and I'm now at Weill Cornell Medicine, the Department of Anesthesiology there. I should mention disclosures. I do have some research funding for unrelated work, and I also, as mentioned, have this book that's out, so that is a true financial conflict of interest. And then I was asked to just put up some learning objectives related to the talk. So humans love origin stories, and Marvel Comics figured this out a long time ago. If you are a fan, you'll know things like Captain America, where the entire film is really sort of about how did this guy become this guy. Right? And if you go back and look, there's a lot of these stories, and it's very satisfying to learn how we got to where we are. But there's also a lot of other things that can be learned from that, not just sort of the satisfaction of a good story. But this particular origin story is about how did we get from wards that look like this to intensive care units that look like this. And of course, this is a long, complex history over about 100 years. But at the same time, it turns out there is one key moment in that history. To kind of set the stage and give you a sense of where we were just a little over 70 years ago, this is a quote from a cardiologist named Eugene Braunwald, who wrote, "As an intern in 1952, we admitted patients with AMI wherever a bed was available on the medical service, but always as far from the nurse's station as possible, so they would not be disturbed by the commotion, especially the frequent telephone ringing. It was not uncommon for me, when arriving on the medical floor at 6 a.m. to draw blood to be sent for testing, to discover that one of my AMI patients had died quietly during the night. Older physicians accepted this as just the way it was." So to sort of give you a sense of where things were just 70 years ago, there was no invasive mechanical ventilation. You could give oxygen through masks or tents. There were no blood gases. There were just a few antibiotics available. There were certainly no ICUs, and there was a lot of a disease that hopefully no one in this room has seen, poliomyelitis. So this story is about an epidemic of polio. And for those of you who haven't thought about it, I certainly learned nothing about it in medical school because we think of it as a kind of a dead disease. But it's an enterovirus, so it's oral fecal transmission. It's actually very similar to COVID-19 in the sense that the majority of people who are exposed to it and get it have no symptoms. But those who did got the sort of non-specific symptoms of childhood, the fever, nausea, lethargy for a few days, and then it would be gone. But if you were unlucky, about 5%, the virus exited the gut into the bloodstream and hit the spinal column, and particularly attacked the nerves that controlled muscles. And so you would get images like this of children in braces, crutches, in wheelchairs. And then, of course, if you were very unlucky, it hit the muscles of respiration. Now, there were two forms of respiratory paralysis from polio. One was the spinal form that literally just hit the muscles that control breathing, but there was also bulbar polio where it hit the bulbar nerves. And so, as mentioned, regular people sort of don't know the term aspiration, but of course, people were dying of aspiration with bulbar polio, with the secretions in the back of their throat and drowning from that. And it had about a 90% mortality. Now, there was absolutely nothing to be done for polio until 1928 when this man, Philip Drinker, invented the iron lung. He walked by a colleague, Louis Agassiz Shaw, doing experiments on a cat, and yes, that is a cat in the photo, who was using a plethysmograph to measure the size of the breaths the cat was taking. So he curized the cat and took that plunger and pulled it out of that box that was sealed around the cat, got a measurement of the volume. He was also interested, actually, apparently, in whether the cat could breathe through its skin, which apparently in 1928 they weren't sure about mammals. And they were able to definitively prove that the cat did not breathe through its skin. But what Philip Drinker recognized was that if you kept using that plunger in and out, of course, you could create a negative pressure system of ventilation. And so what you ended up with was what we think of as the more modern version of the iron lung, which is the standard negative pressure ventilation that became the way to support those who had respiratory paralysis. Those actually were portholes that they welded on to these because they had to get the nurses' hands in there, and nurses hated these machines because it was obviously incredibly difficult to keep people kind of clean when they were in these machines. There are descriptions of them stopping the ventilator, the iron lung, and sliding someone out and washing them within sort of 2 minutes with 6 people, and then sliding them back in as someone sort of turned blue. So they were not the be-all and end-all, but they were certainly a huge improvement. But importantly, when it came to bulbar polio, they were completely ineffective because you just got aspiration as people sucked their secretions into their lungs. But by the early 1950s, polio was really synonymous with care in the iron lung. And what you had was these centers that were respiratory centers in the middle there where they had a ton of iron lungs and could care for people with polio. You also had a number of other things happening at this time. Up in the upper left was battlefield medicine and a lot that was being learned about resuscitation. In the bottom left was the dialysis machine that was being deployed in the Korean War. The upper right there is Walter Dandy and his brain unit, which was this idea of having a place that had specialty care. Although they couldn't do very much for people, they recognized that having some expertise in a specific area was helpful. And then on the bottom right there, what looks like something out of Willy Wonka was a very early ventilator that was used in the occasional operating room in the United States and a little bit in Sweden, but really not in the rest of the world, and even in those countries, just a smattering of places. But what you definitely didn't have was any concept of bringing these things together. So that's where this story comes in. And the story takes place in Denmark in 1952, and in particular at one hospital called the Blydam Hospital. This sadly has been knocked down, but was the quite beautiful infectious disease hospital for the city of Copenhagen, and in fact, the entire surrounding area. And the man in charge of this hospital, Henry Kai Alexander Lassen, was actually a real world expert in polio. He'd seen a lot of it, but they'd never had a major epidemic of polio. And so at the hospital, they had 1 iron lung and 6 what they called cuirass respirators, which is basically a poor man's iron lung. It just straps over the chest and creates negative pressure. You can imagine it's really only useful sort of very, very mild respiratory failure. But this was enough until the summer of 1952 when this started to happen. They started seeing 50 cases a day of polio coming into the hospital, and most importantly, 10 to 12 of these per day had respiratory failure, and the majority were bulbar polio. I was able to travel to Copenhagen, and in their city archives, they had this book, which I took a photo of here. This was their book of deaths for 1952, where every single death in the hospital got recorded. And if you flip through, starting in January, it's diphtheria and pertussis and tetanus, and then you get to July and August 1952, and it's just polio, polio, polio. And by mid-August, their mortality rate for patients with bulbar polio was 87%. It was that dead on 90% that was quoted in literature. Now they were at their wits' end because unlike the United States, where polio is considered the summer plague because it would peak in July and August, in the Scandinavian countries, it tended to peak in September and October, being further north. No one fully understands why, but that was the reality. So they knew this autumn ghost, hence the title of my book, was not going to peak in terms of the number of cases they were going to see for at least another month or 2. Now, there was a young doctor there, essentially a resident or fellow by the name of Mogens Bjornboe. He was quite experienced, but he was still in training, but he was very well respected by Dr. Lassen, the head of the hospital. And he started bugging his boss to bring in this anesthesiologist he had met. Now, the book has a full backstory on how the two of them met. Suffice it to say that Bjornboe knew about this guy, Bjorn Ibsen, who was working across the street as sort of an itinerant anesthesiologist. Now, who was Ibsen? He was a young doctor who had initially started training in surgery and then realized that it was a pretty crowded field being a surgeon in Copenhagen. And he was also very interested in this very, very new specialty of anesthesia. He was interested in becoming an anesthesiologist, but it literally didn't exist as a specialty in Copenhagen or in Denmark in the 1940s. In fact, anybody could give anesthesia. It was sometimes the medical student, sometimes the secretary for the surgeon, sometimes, a nurse pulled in. It sounds terrifying, and I think it was. And there was a recognition that this was something that needed to be sort of professionalized. Ibsen was told, though, if you want to learn anesthesia, you can't learn it here, you need to go west. And so in 1949, he went to Mass General Hospital and trained under Henry Beecher for a year. Now, he not only learned anesthesia, but he also had his eyes open to what he viewed as a different culture and way of thinking about medicine. And these are a couple of his quotes about that time. At conferences, the young American doctors expressed themselves freely and without inhibition. I began to understand here that I was among doctors who thought differently and along other lines than those I was familiar with. Now, Lassen was not particularly interested in meeting Ibsen, but he relented because he had nothing else to try. So on August 25th, 1952, he invited Ibsen to join him in his office along with the entire rest of the hospital, essentially. There were about 20 people there. And Ibsen came, and Lassen said to him, "What do you know about taking care of polio patients?" Ibsen had to admit he'd never cared for a polio patient in his life. Now, this is where I think Lassen deserves a lot of credit. He's a senior professor of infectious diseases. He absolutely could have kicked Ibsen out at this point. It would have been very reasonable, but instead he said, "I'm going to show you the hospital, I'm going to show you the patients and what they look like who have polio," and he took them on a tour of the wards. And what Ibsen noticed was this: a lot of the patients who were in extremis dying from polio had hypertension, tachycardia, twitching, confusion, and clammy skin. And he asked Lassen about this. And Lassen said, "This is end-stage polio. It's the virus overwhelming the brain and the kidneys and the body's shutting down. There's nothing more to be done at this point." Ibsen looked at these same symptoms and said, "I think this is carbon dioxide retention syndrome." Now, why did he think that? It's sort of obvious to us now. If you can't breathe, you get buildup of carbon dioxide. But at the time, this was not well understood. And this is one of those great coincidences. It turns out Bjorn Ibsen was a world expert on carbon dioxide. He had been playing with this enormous machine in his operating room for the past year called the Brinkmann Carbovisor. And this was a new machine. People didn't have it. It measured end-tidal carbon dioxide. And so he had sat in the operating room bagging patients down, watching the end-tidal tracing, and observing his patients. And he noted that when he stopped bagging them for a while, they developed exactly those symptoms that he was seeing in the polio patients. And he had, in fact, just that same year published a paper on his observations in the operating room. They're so simple. It's literally the tracings of carbon dioxide, end-tidal CO2 in healthy patients and in the operating room. So he was confident that it was carbon dioxide retention killing these patients, so he recommended a tracheostomy for these patients to protect the airway. And Lassen said, "Well, we've tried that and it doesn't seem to be enough or to do anything." And this, of course, was the key piece. He said, no, you've got to give positive pressure ventilation to actually, blow off the carbon dioxide. And this was kind of radical because it was not used outside of the operating room, except in another strange coincidence, Ibsen actually knew that it had been. He had with him in his briefcase that day this obscure paper from the Annals of Western Medicine and Surgery by Albert Bower and V. Ray Bennett. They were at Los Angeles during the 1949 polio epidemic there, and they too had seen a lot of bulbar polio. And V. Ray Bennett had worked in World War II with pilots and flights and had been doing some sort of technological innovations around breathing at high altitude. And he was tasked with creating what was called the Bennett positive pressure respirator attachment, which hooked up to a tracheostomy and worked in sync with the iron lung to provide positive pressure at the same time as the negative pressure. And in this obscure paper that Ibsen had stumbled across, they'd reduced the mortality from 90% to 20% in their patients with bulbar polio. Now, any of you who might know Selma Kelmy, she was an anesthesiologist at UCLA. She was actually in this epidemic in 1949, and I was able to interview her about her experience there. So the crucial piece, though, here that Ibsen recognized was you didn't need the iron lung. You didn't need the negative pressure ventilation at all. You just needed that positive pressure. And so what he proposed to use was a Waters to and fro circuit, a very simple circuit used only in the operating room to take care of patients. Lassen apparently was only semi-convinced, but he didn't have anything else to try, so he said, okay, I'm going to let you try this on one patient, and I'm going to choose that patient. The very next day, August 26th, it was admitted to the hospital, a little girl by the name of Vivi Ebert. She's about 9 in this photo here. She was 12 at the time. She lived in this house in Copenhagen with her mother and her grandparents, and she had classic bulbar polio. She was going to die. She had a 90% chance of death, and she was in extremis by the 27th the next morning when Lassen rounded on her. So Lassen pointed to her and said, she's the one, you can try it on her, because he knew she was going to die without any intervention. And so he called in Ibsen. They called in an ENT surgeon to do a tracheostomy, and then Ibsen made a small mistake. He was really worried she was so sick and so end stage that if he gave her anesthetic that she might arrest and die. So we asked the surgeon to do it under local anesthesia, which he did, but had some extra bleeding because of it. And so when Ibsen took over, she had gone into bronchospasm on top of being near death. And we have his minute-to-minute record of his entire care of her from the moment he took over. And he wrote, now in a situation where we cannot perform ventilation because of her spasms and agitation. There were about 20 people in the room watching. They literally left to go to lunch. They didn't want to see another little girl die. And Lassen said to him, if she's still like this when I return from lunch, you need to stop whatever it is you're doing. So he took a risk. He broke the bronchospasm. He gave her pentothal 100 milligrams, and he got lucky because she did not arrest on him. And she stabilized. He was able to bag her, ventilate her. She woke up, and about 15 minutes later, he wrote, the patient is immediately warm and dry. Everybody came back from lunch, and it was truly, I hate the M word, miracle, but it was truly like a miracle had occurred because they knew the natural history of this disease, and they knew that she was otherwise going to die that day. So they hand ventilated her overnight, 3 physicians taking turns at her bedside. There was only one problem. He had just shown that this works, but there were no ventilators. There was no machine to roll in and hook her up to. But Lassen recognized a good thing when he saw it, and he said, right, we're going to do this with every patient who comes in with respiratory failure. So what did they do? They only had a certain number of doctors and nurses. They called on the medical students of Copenhagen, and they asked them to come to hand ventilate these patients 24 hours a day. Initially a few dozen, then hundreds, and ultimately 1,200 medical and dental students participated in the care. They worked in 6 to 8 hour shifts, hand ventilating with 10-minute breaks for cigarettes and food, and they did this for months. Now, it was incredibly exhausting, but also exhilarating. They got to know these patients because, of course, polio doesn't actually impact the brain. So once they were stabilized, these patients were awake. They read to them. Apparently, Winnie the Pooh was very popular, and they became very close. And we actually have some film footage of them doing this. And one thing to note is that, these are classic anesthesia bags. So if there's a kink in the oxygen tank, it does not reinflate. These are not self-inflating bags. They actually hadn't been invented yet. So there are lots of harrowing stories of all the things, that could go wrong with that. But you can see it was incredibly effective, also exhausting sitting at the bedside like this for that many hours. Not something we would probably do anymore, but of course they had to feed them. A lot of them did get nasogastric tubes, and they would literally just blend stuff up and stick it down the tube. It was very sort of primitive, but it worked. Now, there was one other thing that had been a problem, and part of the reason that they didn't understand what was going on. And the question was, in the blood, was it acidotic or alkalotic? And they were under the impression that patients dying of polio had a metabolic alkalosis. And this was because they could only make one measurement of the blood. They couldn't measure the pH. They could measure what was called total bicarbonate, which was in fact a combination of the carbon dioxide and the bicarbonate in the blood. But they didn't understand that. What they saw was that if the bicarbonate was low, that these patients seemed to have a metabolic acidosis. And so they extrapolated that if the bicarbonate was high, it must be a metabolic alkalosis. Now, this man, Dr. Paul Astrup, was the head of the laboratory, and he said when Ibsen started to explain this whole thing about carbon dioxide, he said it was like a light bulb went off. He said we just hadn't thought about carbon dioxide. And he recognized that if Ibsen was correct, in fact, their understanding of what the pH of the blood was totally off, and he wanted to test this. Now, he didn't have a pH monitor. There was none that was used in hospitals to measure the pH of blood. But he knew somebody who did. Radiometer AS, a company down the road, had created a pH monitor for Carlsberg Brewery, who wanted to be able to measure the pH of their beer, which was apparently more important than the pH of blood those days. And he called them up, and they offered to lend him one of their pH monitors, which apparently worked with a blood sample as well as a beer sample. And he was able to test one of the patients dying of polio, and sure enough, the pH was extremely low. And he put this all together and recognized that you needed to triangulate, right? You needed the pH, you needed the total bicarbonate, and from that you could figure out how much carbon dioxide was in the body and understand the true relationship between the breathing and the metabolic situation. And so he started running blood gases on people, having created a system that could do it quickly enough for it to be meaningful as feedback to the people at the bedside. And he wrote, by January 1st, 1953, we had done 705 determinations of pH. So this is the first true clinical use of blood gas analysis in the care of patients. And in fact, for a very long time in Scandinavian countries, they would describe it as an astrip rather than a blood gas, and people would call for an astrip. So by the end of March 1953, of course, the epidemic had peaked and ended. They had gone from an 87% mortality for those with respiratory failure down to about 36% midway through the epidemic, and all the way down to 11% at the tail end. I mean, these are numbers that we will never see. It's really, I find, quite extraordinary to think about what that must have been like to be there and experience that. However, as I mentioned, there were a lot of complications, and I don't want to minimize the sort of stress and trauma of this. I mean, anything and everything could go wrong. They were making this up as they went along. You could run out of oxygen. They had issues with tubing and kinking. The trach tubes would slide out because they were metal. There was mucus plugging, suctions broke, decreased preload because of the ventilation. Everything happened that could happen. But of course, overall, it was incredibly successful. But I don't want to minimize this because I think that it's important to recognize that although this is very much a triumph of medical innovation, it was also at times incredibly traumatic for those involved. Particularly, as you saw, there were a lot of children, not all, but about 50% of the patients who had severe polio were children, and they're sitting at the bedside ventilating these kids 24 hours a day, getting to know them. So when there was a death, it was just horrific. And one of the medical students, I didn't get to interview him, but someone else who wrote about the epidemic did. He since died. And he described finishing his time caring for these patients and going back to medical school and to medical studies and being in a fog. And it very much, his description sounds so much like what people had battled kind of coming out of COVID. And he described going on a vacation to try to kind of clear his head, and he went skiing. And this is his description of dinner one night. He said, I said little during the meal, concentrating on eating. I would occasionally return conversation, but rarely took the lead. As the dessert was served, one of the other guests unexpectedly cracked a bawdy joke. After a momentary embarrassed pause, all in the room roared with laughter, none more so than myself. It seemed that a safety valve had opened, and suddenly I felt able to cast off my reserve. But as I laughed, the tears started to flow, and the laugh slowly changed into cries. Heart-wrenching, soulful wails. At first unnoticed, gradually, one by one, the diners stopped laughing until the whole table went silent and stared at me, their mouths open. I buried my head in my hands, and at last the cries and mourning and tears for the children came. Now, I feel it's just really important to acknowledge this when giving this talk so that it's not all about a happy, successful event, and to recognize that as in COVID, many people struggle with the aftermath of even successful interventions and successful medical care. And what's extraordinary to me is 70 years later, his description still resonates. And I would say the one thing maybe we've gotten better at is acknowledging that can be a struggle for people and that we do need to provide better support and care for those who do experience that sort of stress and trauma. Now, on the flip side, it was recognized that this had been an incredibly important moment with successful intervention. And Lassen wasted no time in publishing this so that the entire world could know about this new intervention and how successful it was. This came out in The Lancet just in early 1953, really before the epidemic was even over. But the numbers, of course, were incredibly convincing. Now, you will note there is one author on this paper, H.C.A. Lassen. This became a point of contention between him and Ibsen. Interestingly, Bjornboe, who's the one who recognized that Ibsen had something to offer, is sort of nowhere in this argument. And I think he really deserves a lot of the credit for recognizing that there was somebody out there who might have expertise to help. But interestingly, Lassen took credit, and people started to flock to the Blydam Hospital to learn about this technique. And of course, not that quickly, but soon after, they recognized they needed something other than students and brought in what they literally called mechanical students to take over the care. And so the Engstrom is probably the most famous of those ventilators. It actually did already exist up in Sweden, and Engstrom himself brought 2 of them down to the Blydam to start experimenting with in the care of these patients. But what was really novel was the idea that these could be safely used outside of an operating room. So what about Ibsen? Well, he finally got a permanent job. He didn't get it at the University Hospital, which is where he wanted to be. There's a whole story with that. But he ended up taking a job at the municipal hospital, essentially the community hospital for the city down the road. And he was tasked with care of patients after surgery. And in these windows here, he first created just a post-op recovery room, which was open during the daytime. But he had a vision. And he recognized that he wanted to create more than just a PACU. And so in December 1953, he opens in those rooms what we would call the first modern intensive care unit. Now, why do I say that? Well, what he took from the polio epidemic and what he learned there was that you needed a dedicated area, 24/7 staffing, blood gas analysis, invasive mechanical ventilation, and specialized nursing, that was all important. Based on his experience as an anesthesiologist, he added in the knowledge of resuscitation and other organ support, as well as the idea of frequent vitals and monitoring, which he sort of adopted from the operating room. And then this is the last crucial piece. He understood that this ventilation could be used not only for the care of patients with polio who had respiratory failure, but truly anybody who had a severe form of respiratory failure from a whole range of problems. And so that, to me, is where he goes from being just an anesthesiologist taking care of PACU patients to a true intensive care physician. This concept did catch on. It took a while. 1958, so 5 years later, you see the first 3 ICUs in North America, Peter Safar in Baltimore, Max Harry Weil in Los Angeles, and Barry Fairley up in Toronto. And Peter Safar comments, he said, we knew what they'd done at the Blydam, and he recognized that this was important. Barry Fairley is still alive, and he actually wrote a nice piece that just came out this year describing kind of taking care of patients in that first intensive care unit. And it was the Wild West. I mean, if you think about it, their first ventilators had no alarms on them. So he describes how the nurse would turn away, and if the ventilator disconnected, literally the patient died. And how they then had to figure out a way to create an inline alarm system that then became the progenitor for modern alarm systems as we know them. But that was the sort of the place they were in when they were dealing with those first ICUs. So what did we learn from polio? Well, we learned a lot. From that one epidemic alone, we got ventilators, blood gases, respiratory physiology, and ICUs. And John West writes about the fact that this was sort of created a renaissance in respiratory physiology, as there was this realization, as Paul Astrup said, like they didn't even think about carbon dioxide. There was so little understanding by bedside physicians of what was going on with respiration. But there's also other things that came from polio. And a couple of these, and this is something that was really new to me in learning about this, rehabilitation medicine. A lot of the focus on how to help people recover from severe illness comes from the need to help polio patients rehabilitate and get strength back. And particularly Franklin Delano Roosevelt in Warm Springs in Georgia was considered this mecca and kind of held up as the best example of how to provide rehabilitation. Disability rights, a lot of the early advocates for disability were polio survivors. Vaccines, of course, and long-term sequelae of viruses that I'm going to touch on later. Now, if you need any ad for vaccination, this is it. This is cases of polio in the United States, in the blue there. 1955, the Salk vaccine gets introduced, and you just see this precipitous drop in cases after that. And essentially, we've been close to zero since then. There was just one case last year in New York. Now, in terms of other infectious diseases, we've had a lot, but actually not that many until really we got to COVID. And this is my little schematic, of what we've had. And really, through HIV, which was sort of a slow burn epidemic with regard to intensive care, I think of SARS as kind of the first wake-up call we had that, oh goodness, there's infectious diseases out there that can be really scary and require intensive care. But I want to actually touch on a different infectious disease that I think very few, if anyone in this room is actually taking care of, but I think makes an important point, and that's Ebola. Now, of course, the Ebola outbreak that occurred in West Africa now a number of years ago was very scary and was ultimately contained mostly there. I actually had 2 colleagues in Toronto who went and helped care for patients there. But there was one observation that was made that I think was really important. This is a paper that came out reflecting on the patients who, for one reason or another, got Ebola and were able to receive care outside of West Africa in high-income countries, mostly healthcare workers who had gone in to help, who were then evac'd out, occasionally someone who got transmission in a high-income country. And there is a table in this paper that is a description line by line. I mean, it's almost like something out of the 1950s of like what happened to each of these patients individually. And you probably can't see it very well there, but it basically says, I have to get close here, survived, survived, died, survived, 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 died, died, survived, survived, survived. It doesn't sound like what we expect from Ebola. And in fact, if you tally up the numbers, the mortality is 18%. And that compares to 40 to 90% for those patients who received care in West Africa. Now, my understanding, talking to colleagues, is the 40% is really when they were able to implement in a specialized center basic health care. But 80, 90% is more what you see when there's really nothing in place. But to me, this is really important because it actually says none of these centers taking care of these Ebola patients in high-income countries had experience with Ebola. So this was not any fancy new technology or treatments. This was doing standard intensive care for these patients, and that they were able to drop the mortality from this disease enormously. And so this is in some ways, I would argue, as close as we'll ever get to a randomized controlled trial of what is the benefit of intensive care in a severe infectious disease or really severe illness, and to show you that in modern times, it really makes a difference. And I would also argue that, in fact, COVID-19, the advances in understanding we did have some clinical advances, steroids, monoclonal antibodies, antivirals, non-invasive ventilation, proning, more ECMO. These are all important, but compared to sort of those types of numbers and the impact they'd made, I sort of have a kind of meh feeling, right? Like they're important, don't get me wrong. I believe that, what was done was really great incremental improvements in care. But I would actually argue, in fact, what we got most from COVID was a recognition that in order to understand and implement these things, we needed really good research platforms. And we needed to be able to pivot and do research quickly. And that a lot of the advances from COVID are really in that arena rather than actual huge changes in our care. And that, in fact, do what we do and do it well when it comes to providing care was in some ways what we just needed to do with COVID, and that we got our best results when we just provided our standard critical care and didn't deviate. And I would argue also that what we provided was not all that different from 70 years ago in Ibsen's ICU. A few more gadgets and gizmos and medications to choose from, but fundamentally, these features still absolutely apply. Now, going forward, what are we looking at? Well, I think war is a big concern as you get this upheaval and mass migration of things like refugees. There's been a lot of concern, particularly about tuberculosis related to the war in Ukraine. Speaking with people from the WHO, they kind of admitted to me that they've downplayed this a little bit because multi-drug resistant tuberculosis is a major concern in the Ukraine, and they really did not want refugees to be unwelcomed in other countries because of fear-mongering around MDR tuberculosis. That said, as providers of care in operating rooms and intensive care units, I think it's something that you need to be aware of, that it is on the upsurge. And while we generally don't think or talk about tuberculosis very much, interestingly, it was the biggest killer period in the 19th century. And certainly there's a lot of worry about its increase. This is just one study that was a simulation in China of rates of multi-drug resistant tuberculosis out to 2050 and real concerns of, it will be increasing over time. Another one that we've certainly been feeling a lot is the issue, I think, of climate change and how this may change the diseases that we see and take care of in the hospital over the next 20 to 50 years. This is, again, just one simulation specifically of valley fever, relatively obscure disease, but one where you can see that it goes from being located in just the southwest of the United States, and suddenly it's going to be half the country that's at risk. I think more concerning probably than valley fever are things like dengue and malaria. Apparently, mosquitoes with malaria were just found in New York City. And so I think it really may change the face of our sort of diagnosing and diseases we see in intensive care units, and potentially put a lot of strain on places that have not traditionally had to worry about such things. Now, the last piece I want to really talk about is about the viral infections themselves. This is a guy named Bob Kraus, who's on drums there on the Blue Jackets band in 1948, and I love the fact that we're in a space that sort of feels like it's the sort of ballroom he would have played in. And he was in his teens then, and about, I think 2 years later, he got polio. And he was in an iron lung for weeks and ultimately got out and went on to lead a full productive life with really minimal sequelae. He became actually a professor of clinical psychology at Columbia. And I first learned about him because I like reading the wedding announcements in the New York Times. And back in 2020, there was an announcement of the wedding of his son. And it described how his son was getting married on an aircraft carrier parked in the Hudson River at 125th Street. Now, this was COVID times, so the fact that he was getting married outdoors somewhere was not crazy. But the aircraft carrier part was a little bit weird because this guy was not in the Army or Navy or in any military service. And it described how this aircraft carrier was conveniently parked directly below the apartment building that his father, Bob Kraus, lived in. And that not because of COVID, but because of polio, Bob Kraus was now back on a ventilator and unable to safely leave his apartment to participate in the ceremony. And so they were thrilled to have found a place where he literally could watch out the window as his son got married below on this aircraft carrier. So I was able to contact Bob Kraus, and he shared with me his story, but he has post-polio syndrome. It's not something I think a lot of us are very aware of, but I think is really actually important for anyone who takes care of patients in any way related to breathing to know about. It was first described in 1962, and it's this constellation of symptoms: weakness, fatigue, pain, functional loss. Diagnosis of exclusion, which is the frustrating part. But it seems pretty clear that people who have had any form of paralytic polio, even if they've regained full function, do seem to be at risk. The estimates of the percentage of patients who get this are anywhere from 20 to 80%. It's really vague because there are people who had polio and actually had weakness and never knew it, for instance. So there's a story of one man I met whose sister supposedly didn't have polio, or maybe had, kind of stuffy nose type symptoms. And then she started to develop this post-polio type symptoms. And everybody was confused because supposedly she'd never really had polio. Then they measured her legs, and one leg was slightly shorter than the other, which is really a telltale sign of someone's muscles having been affected from polio, and her brother had polio. And so it was recognized that she actually now has quite a severe case of post-polio syndrome. The estimate that most people put out there is about 50%, and so it is, there's not an enormous number of known polio survivors, but there's an enormous number of people who were exposed to polio and may or may not know that they had it. There is now a relatively old research article, a review article about this in JAMA, in case you're interested, that came out in 2020. And in terms of what's causing it, there's a number of theories. So the basic concept of polio is that it kills off some of the neurons that control the motor units, and that for the people who then recover some function, it's the other nerves that take over. And so you get basically a single nerve that gets bigger to cover as many motor neuron units as possible to try to regain function. And so that this works, and as I said, for many people they regain full function, some people regain partial function, but there's therefore a number of concepts out there. One is this reactivation of polio itself. That's kind of been debunked in the sense that although poliovirus has been occasionally isolated in the CSF of people many, many years later, the majority don't seem to have it anywhere in their body. So we think most people really have cleared polio. The other is that this is an autoimmune reaction. Is it something like rheumatoid arthritis that sort of it stimulates some sort of response that rears its head years later? I think most people think it's this last one, which is that there's essentially some sort of metabolic fatigue of the remaining motor neuron units, that they've basically grown so big. I always think of it as kind of Little Shop of Horrors, that they need to be fed and just you can't keep up, and you get this new fatigue. It's incredibly frustrating for the people who have post-polio syndrome, because many of them went through this rehab period in their youth of being told push, 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 you'll get stronger, you'll do better. And that's their mindset. And this is a lot like, chronic fatigue syndrome, where if you push a little too hard, you then have a major setback. So it's a total shift in mindset for these people. And the other thing, though, to be aware of is that they have a terror of anesthesia. And anytime I speak to polio survivors, I get a million questions about how do we safely get anesthesia. Having looked at the literature, there's very little out there about it. There's a few studies that do suggest increased susceptibility to non-depolarizing muscle relaxants. There's also some kind of anecdotal data that says that these patients just take longer to emerge from anesthesia. It seems like the biggest issue is really just being aware that these patients are at risk for it and monitoring of their state in the postoperative period. So these are not people you want to send home immediately after their sedation for whatever minor procedure. These are people that you would want to keep monitored in a highly monitored setting for a prolonged period of time. I think, though, this also brings up one last important issue, which is that polio is not the only virus that can have long-term consequences. Of course, probably the most clear-cut is the varicella-zoster connection, where you get chickenpox as a kid and you end up with shingles later in life. That's a true reactivation of a virus that's still lurking there. But there's no rhyme or reason to it. I mean, we know some things that sort of increase your risk of having an event, but it's pretty mysterious as to when and why people get a shingles flare. The other one that I think has gotten headlines recently is Epstein-Barr virus and multiple sclerosis, and some really compelling data that there does seem to be a relationship here that's pretty strong. So really suggesting that there can be these 20, 30, 40, 50-year downstream consequences of the infections that people have in their youth or when they're a little bit older. And I think this raises a really scary question around COVID. So I'm not talking about long COVID, because to me, long COVID is like someone who has had acute polio and then has some residual paralysis, right? That's that sort of short, long-term piece. So that's not what I'm thinking about. What I'm thinking about is there like a post-COVID syndrome that's going to happen 20, 30, 40 years from now. This is just some numbers from Canada from 2022 that showed with antibodies testing that almost everybody, almost 100% had antibodies to COVID, and 50% of those were not from the vaccine, but were from actual infection. And we know at this point, almost everybody has probably been exposed to the actual virus and not just the vaccine. And so to me, it's very scary. There's no answer to this, of course. We can't turn back the clock and stop everyone from getting COVID. But I do think it raises the point that we need to be vigilant going forward and sort of have it in our heads that there could be a relationship. I mean, even figuring out the post-polio syndrome, that took a really astute clinician back in the 1960s to make the link between these people coming in their 60s and 70s and the fact that they'd had polio in their youth. We're better positioned now than we were because we have big data, right? We have the ability to sort of troll for clusters of symptoms and syndromes that we couldn't do in the past. And I do think that there's a good chance, I mean, already COVID does all kinds of weird things, diabetes and, you know, smell and all kinds of stuff that you don't really attribute to viruses. So I think there's a real possibility we could see something downstream. This is the map of Copenhagen from 1952 that was actually in that photo of Henry Lassen from that early picture I showed you. He sent out 6 medical students into the city to track every case of polio. And he put a pin in the map at each address. And each color is a different month of the year. And I want to say I was privileged to get to meet some of these survivors. Their stories are in the book. We actually found the pin for 1 or 2 of them on the map. The map is actually, you can see it in the Medical Museum in Copenhagen. I do want to mention, you know, my bias is that post-polio syndrome happens more frequently than 50%. Every single one of these individuals has post-polio syndrome. Some are back in wheelchairs. All of them have difficulty walking. But you know, they're thrilled and proud to know that they were part of an epidemic that ultimately led to some good and has really changed the world and the care we provide with regard to medicine. I want to leave you with one last film. I use this as a sort of goad for us to do better. This is from the summer of 1953, at the tail end of the epidemic. So they had ventilators at this point, and this is the Blydam Hospital. And what's remarkable to me, this is the first year that ventilators exist, and they are able to get these patients outside of their hospital rooms into the sunshine. And I just look at this and think we need to do better, because if they could do this, then we don't do this anymore. That's the one part I would say, don't do better, don't do that. I mean, every time I see that, I'm waiting for the explosion. It's terrifying. But I do think it really makes the point that, you know, they were able to see that we needed to keep humanity, that it wasn't about the machines, and that it was about ensuring that people saw sunshine, had fresh air, were treated like humans. This little boy here, he actually has a trach in place there, that he's been weaned off the ventilator, but you can see that he still has severe weakness of his arms, needing his little sheriff's badge slings for his arms. But I see him as, you know, an inspiration for all of us to think about the care we provide every day, whether it's in the operating room, whether it's in the ICU, it's all about making sure we give the best care we can for our patients. So I'm going to stop there and say happy 70th anniversary of the first intensive care unit. I think we can all feel very proud of Bjorn Ibsen as an anesthesiologist and all that he has contributed to our fields. And then, my one plug, if you did enjoy this talk, there's a lot more in this book. It's actually written for the general public, although physicians who've read it have said they've very much enjoyed it. But I put that out there because I hope it might be something that you can share with family and friends. It really, may help for them to understand what it is you do every day. It's also just a good story. And I definitely, wrote it with the idea of wanting to help the world to understand the importance of the care that we provide every day in the hospital. So I'll stop there and hopefully left a few minutes for questions. Thank you.
Not sure where our microphone went, but I think we could probably hear anyone who has a question. I wanted to say thank you, Dr. Wunsch, for that amazing presentation. Been looking forward to it. Anyone who has a question, feel free. Yes, Dr.
And I didn't, the question was she was having, I believe, a hip replacement, or it might have been a knee, I can't remember which. She'd had multiple surgeries in the past under general anesthesia, and I looked all this up, and I'm like, oh, can I do a spinal? And I saw things that said yes, and I saw things that no, it'll last a really long time. I didn't know what to do. She ultimately said, well, I've had a lot of generals, and I've had no problems with specifically the muscle relaxants, and everything I looked at were before Sugamadex to reverse relaxants. So I did do a general anesthetic, but I wonder what your thoughts are on spinal anesthesia.
Yeah, I mean, I think to your point, and it sounds like you may even have done a better literature search than I did if you were about to take care of a patient with the issue, that there are very few studies. They are very mixed. Some, most of them are just case reports. Some of them saying, gave a spinal and no problem. Others saying, gave a spinal and it took a while to wear off. And so, I think the main thing is that all of it is safe. It's just a question of recognizing that you may be dealing with prolonged emergence and or duration of some of these things. So I feel like that's my kind of reassurance when I talk to them, is just to say, you need to tell your provider about this. You may need to educate them about this. I often tell them about the JAMA article because they say they have trouble getting people actually to take them seriously about post-polio syndrome because it's a diagnosis of exclusion. So they really like the fact that there's a JAMA article they can point to and say this thing actually exists. And then when it comes to the anesthesia, I do think it's just reassurance that overall it's safe, because there's really nothing that says anesthesia itself is unsafe when done in a monitored setting by someone highly skilled. And I do think that the piece that's important is just the post-op planning and to just be prepared for contingencies. And so that's the patient that, you might, depending on the procedure they're having, you might argue for an ICU bed for them for monitoring overnight, where in your average patient having that bigger surgery, you might say, oh, that, there's absolutely no concerns here. I think it also depends a little bit on what their weaknesses are, right? Because of course, not everybody had respiratory failure or symptoms when they had polio, and that probably does impact whether or not they're at risk for, say, respiratory difficulties after surgery. That said, some of the polio survivors had told me that they've developed weakness in limbs that were not the ones affected when they were young, which is probably that limb was affected or their breathing was affected, and they just didn't know it because it wasn't as severely affected as whatever they were focused on. I think there was a lot of that went on, very subtle impacts that sort of went away or got better and nobody actually recognized. So if it were me taking care of a post-polio syndrome patient, I think I would always assume there was the potential for respiratory difficulty. But I agree. I mean, I think it's an interesting challenge of how do we do research on this population. They're out there, but they're elderly and aging, and they're, thanks to the vaccine, we actually don't have a next generation and wave coming up with this. So their frustration is no one wants to study this because there's a lot of them, but there's no new cases and patients coming up through the ranks. I do think this is where potentially some big databases may help, but knowing people had polio, it's not on our checklist of pre-op questions. And I always think about all the patients I've cared for in the ICU where we've struggled with weaning unexpectedly. Yeah. And suddenly, you kind of scroll back through and think, if I just asked, I wonder what would have happened if I'd asked about polio. How many of these people might have had that in their background? Was I seeing manifestations of post-polio syndrome without even knowing it, right? And, we'll never know the answer, but it's a challenge to study. So.
Yeah, I didn't take it. When I first saw it in her notes, I'm like, oh, well, I'll just avoid socks. And then I said, no, I better look this up. I've not had this before. And the more I read, the more scared I got. But I'm really glad I didn't take care of her after I heard this lecture.
Well, as I said, I think it's all safe. It's just vigilance, right, to make sure that you keep them safe, which we are all skilled to do. Like, that's what we do. But it does take planning, of course, to know that. Yeah.
Any other questions in the audience? One of the things that, yes, sir.
Thank you for that incredible historical medical perspective on polio and the associated, viruses that we've seen thereafter. And you alluded to it briefly with mass immigration and governmental societal breakdown, not just just in some parts, but many parts of the world now, tragically, and the influx of immigration. I mean, it's like the barn door is open, and that horses are out of the barn, and we're going to see it. It's just a question of time. The malaria, the global warming, and TB, multi-drug resistant, dengue fever. It's just the list goes on and on and on. And I can't imagine what that's going to mean to our ICU colleagues in the years, decades to come, but I suspect it's profound.
Yeah, I mean, I think some things, like for instance, on a positive note, WHO thinks they're a few years away from a really effective TB vaccine. We have one now that is only partially effective. And so I think that could potentially be a game changer specifically for TB and MDR TB if we can get that rolled out. But I agree, things like malaria, I mean, it's just kind of mind-boggling to imagine having malaria cases in New York City if that were to occur. And so I do think 50 years from now it will be a different case mix of patients in many of our ICUs, depends on where you work, of course, and many people work in places where they might see that now. But I think the bigger concern is just, as in the burden on ICUs we saw with COVID, whether that burden increases, because the non-infectious diseases aren't going away, right? And that's actually what our ICUs in many ways have been built for. If you look at the epidemiology, the vast majority of patients who come into our ICUs do not come in for infectious diseases. They come in post-surgery, they come in after their congestive heart failure, with their diabetic complications, right? And if you look, it's only a tiny percentage outside of COVID years that we're actually taking care of patients with infectious diseases. So I do think it's going to be a whole new world of what we're seeing as our case mix, and potentially the need to expand ICU services even more than we already have. And the U.S. is better equipped than pretty much anyone in the world in that regard, but it still may not be enough if things get worse. So hate to be the doom and gloom, but we'll hold on to the TB vaccine as the happy part of that.
Excellent. Thank you. Well, your story is one of necessity breeding innovation. I think these are exciting developments that we've seen. And I guess as an intensivist and amateur historian, my question that I often ask is, how do we maintain that drive to innovate absent a life-threatening pandemic or crisis scenario? I don't know if you have any thoughts on.
Yeah, no, I do often dwell on sort of what did it take for this to happen? And of course, every innovation is different and a different story. The piece that I take away most from this that's relevant to thinking about modern innovation is the piece about who Ibsen was, and the fact that he was an outsider. The fact that he was not indoctrinated with this view of, well, this is end-stage polio and this is what it looks like and there's nothing more we can do, right? And he had no training, and this is also, Lassen kind of gets a little bit of the villain role here because of his taking credit, but up front, he listened to Ibsen. He listened to this guy who was 20 years his junior, didn't have a steady job anywhere, in a specialty he'd barely heard of, and he was willing to give him that chance. And so to me, I think it really actually speaks to the sort of diversity and inclusion piece, which is that we are better for having people in our midst and voices in our midst who are coming at things from a completely different perspective. And that's where you can get innovation potentially without the need for something like a pandemic or an epidemic to cause it. It's just having someone come in and see something differently, right? And so that's the part that to me feels like you can't change the coincidences, and you can't change the fact that they had no IRB regulations and could do whatever they want. You can't change a lot of the other aspects of the story, you can't kind of use those aspects of the story in terms of thinking about modern innovation. But to me, that's the piece you can.
All right, everybody, perfect timing. Give Dr. Wunsch a round of applause.
Thank you
so much. Appreciate your talk greatly. Thank you again. Yes, Dr. Wunsch, and I encourage everybody to look into all that information more. It's fascinating. I think at this point there's a business meeting to follow, and so everyone should grab lunch and plan to head back to the Grand Ballroom for session 4. Thank you, everybody, for a good morning session.